Good evening, everyone. Welcome to this Wednesday's teaching, FRCS teaching from the mentor group. Sorry, you can hear some echo, but there's been a technical problem, and that's why there's some delay. The session tonight is ethical considerations for the FRCS exam. The presenter is Mohammed Imam. He is one of the mentors. He is a consultant upper limb surgeon from Norfolk and Norwich. We have other mentors in the group, Abdullah Kashif, and also we have Amjad, who recently passed the exam, who's with us tonight. Please keep it interactive, ask questions on the chat group, or raise the hand symbol next to your name. Everyone who attends can have claim a CPD certificate. Please get in touch with me. And over to you, Mohammed.
Thank you very much, Firas, and welcome everyone. So I'm going to, I think this is a very important topic. It's ethical. You know, nowadays, recently, there has been always one of the ethical scenarios that comes in the exam. And the problem is with these scenarios, it is important because it reflects your attitude and behavior. However, the difficulty mainly, it isn't, the difficulty mainly is that there are no books or no hard consensus on how to answer this, but mainly it's common sense, and it's all about guidance. So I'm going to go through most of these ethical dilemmas, and I've collected this stuff partly during my preparation for the exam a couple of years ago, and also it is crucial. You will be asked these questions in most scenarios. One of the most common scenarios that I'm pretty sure you've been asked during your different interviews is a drunk colleague or colleague who's using or someone who, or a patient mentions to you that on 2 occasions they have smelled alcohol on your consultant's breath during a clinic, or someone coming to you and telling you that someone is abusing drugs or stuff like that. And in these scenarios, there is buzzwords, and there are buzzwords, and you have to use these buzzwords. And as with everything else we do, patients first. So I would tell in the drunk colleague or a colleague who use illegal drugs, my first concern would always be the safety of the patient. However, I have duty of care to my colleague and the hospital too, and that's it. You know, you pass this scenario if you just said these 2 sentences. You have duty of care to patients. Always our first concern is patient safety, and duty to our colleague and the patient and the hospital itself. So patient safety, you would talk to your consultant colleague and send them home. Of course, if you're a day one consultant, as with everything else in the exam, you will enlist the help of another consultant or a CD clinical director if you need to. And then patient safety, you will review all patients seen by the consultant, complete the whole round. You can recall patients discharged by him, ask them to come back and see them again, review their notes and all that stuff. And then duty of care to your colleague, because at the end of the day, this is your colleague, and you know, GMC it's common sense. You have to make sure that your colleague would arrive home safely, so you will arrange for a taxi for them to go home, check with them later to ensure that they've reached home safely. You will discuss with them and try to help, find, you know, like you can suggest occupational health referral and says that this behavior was always not appropriate. And that's a problem with these scenarios. There is no medicine in it. There is no orthopedics. It's actually all about common sense and guidance. And finally, the duty of care to your hospital by keeping accurate records and inform your consultant, your clinical director here, because you're a consultant. It's mainly you have to protect patients from risk. of harm posed by another consultant, colleague, conduct, performance, or ill health, if so. And the safety of patients will always come first at all times. You can repeat that as much as you want during this scenario, and then you can discuss other concerns later on. Another ethical problem is like inappropriate behavior, like consultants making inappropriate sexual remarks to a nurse, colleagues stealing hospital property. So what are you going to do? So generally speaking, I'm not sure if you know that or not. Usually if you have concerns about a consultant, some colleague in regards to behavior or performance, you can always report. There are different pathways. You can report your concerns to your clinical or medical director. You can discuss your concerns with the National Clinical Assessment Center, Service, NCAS, and you can always report your concerns to GMC.
Sorry, Mohammed, quite nice to go over it again because it's very, very important. You touched on the topic of difficulty in colleague in difficulty, and that could come into so many scenarios, so many different scenarios, but you've explained the main three pillars our answer should be based on. And once the examiner hears these pillars, duty of care to the patient, to the colleague, and to the hospital, once you touch on these three, you will pass this question. So if you could go through that again for us, and from the beginning with your slides, please.
Yes. So basically, again, this is an important topic, as I said earlier, about ethical considerations in the exam. And the main problem of these ethical scenarios is that they will come frequently nowadays. It's almost guaranteed you'll have a scenario of an ethical problem in your exam. It's not mentioned in our books. We didn't study it before. We all read it, we had it in courses, but it wasn't written. It's all about guidance, and the GMC website will have that guidance. One of these ethical dilemmas is actually, if you have a colleague with a behavioral problem, like you smelled alcohol on your consultant colleague, a colleague you suspect someone is taking illicit drugs, a patient mentions that during an examination one of your colleagues smelled of alcohol. Difficult colleagues or colleagues in difficulty is a common scenario. And to deal with a drunk colleague, for instance, we'll start with this one because this is the commonest scenario. It's always patients comes first. You cannot start this scenario without saying this buzzword. My first concern would be the safety of the patient. However, you have a duty of care towards your colleague himself and the hospital too. So first you have to talk to your consultant colleague and make sure they stop working. So that's what we call damage control. So if difficult, you have to enlist the help of another senior consultant colleague or the clinical director. And then you have to make sure that you demonstrate that you care about patient safety by saying that you review all the patients that seen by him or her, complete the ward round, recall all patients seen by your colleague on that day, ensure the appropriate cover is arranged for them if needed, because that colleague might be on call, and that might be the next question. The other thing is actually, and that also a common sense, is a duty of care to your colleague himself. So you should arrange for a taxi for them to go home, check on them later, ensure they've reached home safely, and then demonstrate that you have long-term plan and long-sightedness or a vision. You discuss with them and try to help. You suggest referring them for occupational health and insist at all times that this behavioral isn't appropriate. And finally, duty of care to the hospital itself. The duty of care of hospital is just by keeping accurate records, do an incident form, inform, and then duty to your colleague and the hospital. Right. Have a difficult colleague, as I said, the first concern always in every of these ethical scenarios is patient safety. That's utmost important. And then you have duty of care to your colleague himself and the hospital. So can you see that now? Patient safety. So you discuss with your colleague, they make sure they arrive home safely and all that stuff we've discussed earlier. And then recall patients discharged by your colleague, ensure that appropriate cover is arranged whenever possible. Second thing here in this slide, your duty of care to your colleague, arranging a way to go home, make sure they arrived home early, insist that this behavior wasn't appropriate, and this is a buzzword that you should make sure you make your examiner here and discuss with them and try to help and suggest referral to an occupational health. For the hospital, mainly it's all about keeping accurate records and inform your consultant or clinical director about the incident and make sure it is following. If your colleague is doing inappropriate behavior, generally speaking, whether sexual attitude, bad sexual attitude, racism, all this stuff, if you suspect problems from your colleague, if you have concerns of concerns and you have to protect patients or staff from risk of harm, both by another colleague's conduct, performance, or health, the safety of patients will come first. The safety of your colleagues comes first here in this scenario. Also, it's at same importance. And then if you have concerns, there are always ways to report your concerns. So basically, you have to make sure you take these necessary few options. You have to make sure you report your concerns to a senior colleague and clinical director mainly, or the medical director if there is a consultant involved. You can also discuss your concerns with the National Clinical Assessment Service, which gives advice in regards to any concerns, and they give advice to employers, patients, or staff. And you can always report the concerns to the GMC. And then there are three main aspects here. First, the individual health and other factors related to the individual himself. So this slide, I've summarized some of the topics that can be covered. So you have to make sure that your colleague this change in behavior is not due to a physical or mental illness. Maybe he's depressed or she's depressed, or it might be also alcohol. And if there is a major life event going on that have led to this inappropriate behavior, and having this guidance in your mind while dealing with all these concerns would always help. Secondly, you should know, if you have concerns in knowledge or skills or behavior, then you have to assess that and dig deep. There might be a deficiency in education or induction or problems with competence. All these questions you should ask, covering the three main aspects of good clinical practice by the GMC. Finally, it is the job. Is the changes in behavior related to work factors? Is there a problem with technological advances, with work environment, with team difficulties? Is there any major organizational changes? So these are different points you can talk about if you're having concerns, if you're having a significant concern. So always one question you might be asked, and I was asked that before, what is a significant concern? So the definition of a significant concern is mainly a concern in regards to behavior, skills, attitude, and knowledge that might affect patients or staff safety and should be reported. For example, if you're worried about poor clinical performance, if you're worried that your colleague is ill-treating patients, if there is unacceptable behavior like harassment or discrimination, if there is if he or she is breaching sexual or other boundaries with patients or staff, if there is poor teamwork that compromise patient care, if you have any other concerns like fraud or criminal offenses, and that's actually, this list is never exhaustive, and there might be other areas. So these scenarios can take uh, any route. But you can, if you follow these principles, as I said here, so basically you discuss the individual health and other factors, knowledge, skills, and behavior, and the job, and you cover most of them. And it's always patients comes first, and as well in other scenarios, staff safety comes also first. Another scenario that you might have, if you've been asked how would you react if one of your female junior colleagues, your day one consultant and your registrar refuse to treat a patient because he's a known rapist. And this is, that's what I'm citing here. So you should mention the word GMC guidance. Basically, if you're carrying out a particular procedure or giving advice about it and conflicts with your religious or moral beliefs, this conflict might affect the treatment or advice you provide. You should explain that to the patient and tell them that they have the right to see another doctor. So patient safety first, as usual. However, you must be satisfied that the patient has sufficient information to enable them to exercise that right. So if it's not practical for the patient to arrange or see another doctor, you must ensure that these arrangements are made for another suitably qualified colleague to take over the role of your junior colleague, because all patients are entitled to care. Either there are serial killers or rapists, they are all entitled to the same quality of care and treatment, meeting their clinical needs. However, the staff have also rights to, if they are carrying a particular exercise that conflicting with the religious or moral beliefs. But at all times, patient safety will always come first. If in this scenario here also, the other concern that she might refuse to treat the patient because his medical or mental condition might put her at risk. If a patient poses a risk to your colleague health or safety or yourself, you should take all available steps to minimize the risk before providing treatment or making suitable alternative arrangements for that treatment. So it's basically, to summarize here, you should say the word GMC guidance, and it's clear and it's published on the GMC website. You should mention that this is conflict with the religious or moral belief should be respected. However, patient safety and care comes at the core of everything we do. And if there are any concerns or risks, then you can always make sure all available options and alternatives are in place. Another topic which can be important as well is racism. So how would you react if a patient refused to be treated by you, if you're or one of your junior doctors, because he's a foreigner? So there is a protocol here and there is a guidance here that is, just look at this slide. It's really important. You first have to ensure that this patient behavior is not due to his or her underlying medical condition. If something naughty said by someone with dementia, that's it. Live with it. You have to continue treating them because the patient is not willful. However, if the patient is willful, then you have to start with an informal warning. Tell them that the behavior is not acceptable. If the patient persists, then you should give a formal warning. And if the behavior is repetitive, then the patient should be removed from the trust premises by hospital security. So you should make sure the behavior is due to underlying medical condition, followed by informal warning, then formal warning, and then removal from the premises. However, and you always have a however, the care shouldn't be hampered, and the responsible clinician should make sure the adequate arrangements for the transfer are in place. Most trusts have policies regarding dealing with violent, abusive, or racist patients, and most trusts will display them everywhere, as you are aware. And most trusts in the NHS, if not all, have a zero tolerance policy towards abusive patients, and care may be withdrawn from persistent offenders. But at all times, make sure you have you have arrangement for him or her to receive treatment appropriately. So another scenario here that, I'm just trying to go through all common scenarios that you might not find a good solution for elsewhere. If you have someone who's, you're working as a trauma consultant on call, and you had someone who's suppressed a lethal overdose, chance of the bridge and coming with multiple trauma, and she leaves written instructions that she doesn't want to be resuscitated, or he. So how would you deal with her? So basically, remember the four basic principles of medical ethics. This you can use in most of these scenarios. The principle of autonomy, which means that individuals have the right to be self-governing. The principle of non-maleficence, the patient shouldn't be harmed. The principle of beneficence, the benefit of the patient should be promoted at all times. And the principle of justice, which is equality, and equals should be considered equally. You can cite this whenever possible in these scenarios. So living wills or advance directives are valid in the English law. However, an advance directive must be written by a person who actually are competent and has the mental capacity. So if in this patient X, if she had psychotic depression, she wouldn't understand the consequences of her refusal of future treatment, and then she should manage to deal with it. So in this scenario, you must have discussed with the psychiatrist as well to gain further guidance and define the dilemma. If you can, discuss it with a senior colleague or check trust protocols, all these things you can say. So what about performance concerns? And in regards to performance concerns, like your consultant tells you something that you think it's a consultant colleague in the trauma list tells you, in the trauma meeting tells decisions that you find inappropriate and lack of minimal competency, or one of your peers constantly arrive late for work. These are also performance concerns. In these concerns, don't assume that your consultant is wrong. Always discuss, or your consultant colleague is wrong. Discuss with them, find why they make that decision, why they find that decision interesting, and tell them that you would like to learn from the thinking behind that decision. If you're not satisfied, and that would be the next question from the examiner, then you should you suspect that less than perfect care has been provided, you're duty bound to raise your concerns with your consultant. If you find it difficult, then discuss it with the clinical director or the medical director. If there is minor concerns of minor performance concerns, like a colleague arriving late, or you find that your colleague seems to be suffering from stress, all this can be done informally, and you can discuss with them, listen to them, get their feedbacks, and understand what is behind it. A poor performing doctor is someone whose competence, conduct, or behavior pose a potential risk to the patient safety or the effective running of your clinical team. So a problem should be also addressed. Also remember the three main points we talked about: the individual himself, the job itself, the attitude problem, or the knowledge, skills, and attitude problem. So here you have to find a diagnosis. Is that true? Confirm the diagnosis. If it is your junior, then you have to make direct observation, have feedback from previous supervisors, and then have an intervention by, these are all things. So diagnosis, confirm the diagnosis, and then do the intervention by communication of clear expectation, enhance teaching, arrange for peer or mentor support, reduce the clinical workload, and have more protected time for your colleagues. So there is no right answer for these scenarios. And also one good place to find more ethical considerations, if you're looking for one, is actually the GMC website itself. because in the GMC website you will find that you will find few clinical scenarios, and I think they are very helpful if you would like to know more about it. The other important topics that we can discuss as well, I'd like you to take a look on these few questions, which would be consenting, and it's an important topic to discuss as well. Consent for procedures you do. That's one important question that you can be asked, and especially with the current problems going on in the NHS. Consenting is always an important topic that's asked a lot. So I would answer the first question by saying that I work in close partnership with my patients. I consider consent an important part of the process of discussion and decision making. I discuss with my patients the current situation. I answer all the questions. You know, you have to discuss other treatment options, intended benefits, common, uncommon, and rare risks, and share with them the detail of information as much as they want. And then if there are complexity of proposed investigations on treatment, you should also discuss that. And always say the word here, GMC guidance, because that's a reference on which you're talking about. The second topic is always a second question is an important one as well. So what do you consider to be sufficient level of information for that patient? So initially, the English law has tended to regard the level of information required to be that acceptable to a reasonable body of medical opinion, and that's known as the Poland test. However, after the Montgomery case, and you should check this, Montgomery case is not Gynae, I think in Lancaster, the courts have said that they will depart from the approach of the amount of information that's acceptable to a reasonable body to the amount of information the court finds to be appropriate. And that's appropriate for consent. The legal age for consent for surgical treatment is 16 years and over. In such cases, there is no legal requirement to obtain consent from parent or guardian. Usually 16 to 18 is a gray area, but 16 is a legal age. However, if a child is under 16, and if the health professional feels they are capable of understanding the nature and possible consequences of the surgical procedure, you can still consent them. However, legally, you should also discuss it with the parents. And that's also known as the Fraser ruling. Generally speaking, that mainly was highlighted for contraceptive advice. So what's the legal position of a child or parental refusal to treatment? So according to the Fraser ruling, a Fraser competent child cannot refuse a treatment so to be for his or her best benefit in England and Wales. And then parental consent will be needed. So if you think that a child who's less than 16 refused the treatment you think is for their best interest, then you should gain consent from their parents. It was mainly based on the MMR controversy. And there is also one common scenario that you can find is about a kid who's like 14 years old and he's happy to have blood transfusion, who has the parents are Jehovah's Witness who refuse to give them blood transfusion, and there are guidance on the Royal Society of Hematology that you can check.
Sure, Mohammed, you covered this extensively, and you can never cover everything to do with the ethical considerations and ethical scenarios, and consent matters is quite varied and could be anything. But as long as we understand the principles, we can come up with a sensible answer. And you said that very nicely. You say, patients, hospital, colleague safety, patient safety, and hospital. Also, always say GMC guidance. According to GMC guidance, for anything to be ethics or consent, related to ethics or consent. Can I say, just add one comment regarding the Montgomery cases? It's quite complex. I looked at it, and the only thing I could get out of it, to be honest, is that, is the consent should be patient specific. And by saying that, if you have a patient, for example, you're offering a knee replacement to a patient, and anterior knee pain and inability to kneel is very important to a plumber, for example, and not very important to another patient who doesn't kneel at all. So I think that's an example of how the consent should be patient specific to the need. So we need to now, after Montgomery ruling, we need to understand our patients' life and lifestyle and function very well, actually. So it's consent process.
This consenting dilemma is a common dilemma, and it is discussed in most meetings. You'll find it in lower limb meetings, in upper limb meetings, all these meetings. So you just stick to the principles in the exam. Just say, you're aware of the Montgomery, you're aware that you should give as much details as the patient would like to know. As you said, do bespoke consents for this particular problem. Listen to your patient and understand their expectations, their aspirations, and then you can then give them the amount of information you want. How much is, to summarize ethical considerations, it's as you said, patients come first, say GMC guidance, your duty of care to colleagues, your duty of care to hospitals, and that will cover to the hospital, and that will cover everything. And then when you're discussing someone with problems, you should know and understand and find the diagnosis, confirm the diagnosis, and set up an intervention to manage them. And then discuss individual problems for this particular colleague, discuss and understand the knowledge, skills, attitude, all these things that matter, and eventually understand the job and dig deep to get more about the job. If you just say these broad titles, and you can talk as much as you want underneath them, and as I said, the GMC has some good ethical considerations, but this was the topic that I am aware has been asked in the exam before, but it's not conclusive, of course.
Yeah. I mean, I agree with you. These topics have been asked all in the exam before, and they commonly retested. I just want to say also, like when they put an ethical dilemma in front of you, always try to differentiate whether it's a major or a minor one. Major one is the one that's patient safety is affected. Yeah. Minor one is when the patient safety is not affected. Minor one is such as colleague is stressed out, or colleague arriving late at work every day. These are concerns, but they are not major ones. So always show the examiner they understand the patient safety ones are the major ones. The other ones are less major and can be dealt with later on once the patients have been sorted. And also in any ethical dilemma when colleague is involved, the first step always is talk to the colleague first. Yeah, don't jump the colleague and say, I'll straight away call the GMC or call my medical director. Speak to the colleague first, because you might be able to immediately help them. They might just not be aware they are causing problems, and always ask them, whatever the problem is, self-referral to the occupational health department. If they give them a chance to do it, if they don't self-refer themselves, if they're stressed out or whatever, drinking problem, and not self-referring themselves, that's when you raise it to the higher level.
Basically,
if a colleague, if you finding out a colleague is doing too many mistakes, what would you do? How would you approach that? Is it making
the same as well?
Complications and
no, this is also a performance problem. To think about the individual health and other factors. Do they have physical or mental problems? Are they depressed, suffering from another mental illness, substance misuse? And then goes into the second aspect, which is knowledge skills and behavior, and then finally the changes in the job. And if you have serious concerns, you can discuss with others like medical director or the same personnel. Also, you can actually quantify your concerns by auditing their performance, making sure they have making sure they don't have an increased complications rate compared with their peers. And then if you have concerns, highlight these concerns. The next question, if no one makes an action, then you can always contact the National Clinical Assessment Service. You can contact GMC. So, it's always about a hierarchy of things to do. So you always think about the same principles: the individual, the knowledge, skills, and behavior, and then the job, and then take it further.
I think what can happen then, that you report that issue to the clinical director, and the clinical director tells you, okay, Mr. Imam, can you help us out and get this sorted? So what would you do if colleague is underperforming, let's say, and they're asking you to formulate a plan?
So one way of assessing that, if you think your colleague is having an increased reinfection rate after his hemi-arthroplasty, for instance, so first they should stop operating, because patient safety comes first. That's one thing. So that's one thing should be an action. They should have, they should stop whatever they're doing now. And that's usually the decision of the medical director or the clinical director, of course. And then you do service evaluation, which is audit a quality improvement project, by assessing actually, because your colleague might have 3 infections in the last week, and he never had he didn't have an infection for the last 3 years. So what is different? Is it him or is it others? Is it the cases? Is that problem is exclusive for him? So now you do root cause analysis to make sure that actually he's the one to blame. And if I'm worried about his performance and I have evidence supporting my concerns, then that should be taken to the other level by doing a proper investigation and having a clinical incident form and discussing that in the governance meetings, and then decision should be taken on a higher level, not just me telling them do or so. Yeah. But as I said, with everything else, safety comes first.
Thank you, Mohammed. I think that's what I was getting at. Sorry, Abdullah. Go ahead, Abdullah.
Sorry. Yeah, I agree with everything you said, Mohammed. The next level, I would say, is so the first thing is to say establish whether it is actually true or not. So information gathering exercise, and that could be like an audit. So you can start by doing an audit to compare someone's practice with other people. Next, find out the cause of it. It might be the consultant, it might be his registrar, his junior, the scrub nurse, the theater he is operating in, because some hospitals have a specific theater for a specific surgeon. So again, find the root cause of the root cause for the problem, root cause analysis. While, as you said, protecting patients. So you could say, I have a duty to the patient, as you said, which is the paramount, a duty to my colleague, a duty to the trust, and then a duty to myself by protecting my reputation, and a duty for all doctors by protecting their reputation as well. By mentioning all these, giving this set plan, I think the discussion will take you where they want to take you.
And I totally agree with Abdullah. And using all these buzzwords makes you a 7 at least. It's simple. It's like and we go to hospitals every day. It's a career for paying the bills, but there are easier careers. But we're mainly there for patient safety. That's the thing. So I think you always have to highlight these buzzwords like root cause analysis, gathering information, make sure all precautions are in place, who to blame, what's the problem, and then investigate accordingly.
Excellent. I think that's what I was trying to highlight with my question. Service evaluation. Don't always assume it's the colleague fault, because it could be other causes for the complications. But because patient safety is paramount here, we have to do root cause analysis to find out whatever the cause is and eliminate it. if the colleague, if a problem turns out to be a colleague requires more training, then obviously he could be supervised by a senior colleague, he could be mentored, he could be offered educational courses and things like this. So always show you supporting your colleagues, yeah? Protecting patient safety, but also supporting your colleagues. So if your colleagues require training in particular areas, we should be supportive to them. And that's also important to show in the exam and in real life that will be examined, our support for our colleagues. So don't always say, oh, I exclude, my colleague will never be, go home, security taken. No, we will support the colleague unless, we'll leave any more drastic measurement as a last resort. So assessment of capacity is important. Thanks, Amjad. Assessment of capacity of the patient, whether it's elderly or a child.
Yeah. And so the points where whether is this is the capacity or this is this kind of dementia, is it related to the injury itself, or whether it's something kind of well established? So then the examiner would take you to which route that he is going to talk to you about.
Thank you. Thank you. I think there was one more question to the mentors. Mohammed, if you could, yeah. So
there's a question by Ahmed Hagnassi. What's my responsibility if my patient is found to be HIV positive and he or she refuses to be notified authority? It is, we are as physicians, we're bound by duty of confidentiality to our patients, but this is not absolute, because confidentiality here is mainly at the center of maintaining trust and ensuring partnership, however, without causing harm to others. So in this case,
in every hospital, most of the hospitals, there is a Jehovah Witness liaison kind of committee, and they have this. Okay, the issues here are: is the child, is he GILIC competent or not? If the child is not GILIC competent, but you need to highlight this for the examiner, that if the child is GILIC competent or is the child is GILIC not competent. So this is it's all about higher order thinking and your structure and your principles. So you are aware of the guidance, and that's all it's about.
Who's got the full legal responsibility for this person? And it's very fair to ask who is the person who has guardianship, and that's I think the buzzword. Who is the person who's legally got the guardianship? And if he's in between establishments, moving from one family to the other, whatever, then you have the buzzword would be act in the best interest of the patient. So these are the two buzzwords: guardian and best interest.
Yes, and actually, if you know the guardian or the legal representative who can take consent, you deal with them as if they are parents also. And you always can, you can always contact the court or a legal representative if you have consent. But it's all, I think that's the buzzword here.
There is, and the third thing, that if they want to give you a 7 or probably an 8, I don't know, there is an on-call court representative that you can contact any time of day or night, and they can issue a quick order within 24 hours to legalize whatever you want to do, as long if matters are really ambiguous. But then you have to speak to your colleague first, clinical supervisor, site supervisor, whatever, and then they will contact that person in front of on your behalf, and you explain the situation, and they can issue a court order allowing you to stop or start treatment based on the facts available, in the absence of any person who can act as a guardian. For example, a traffic accident where both parents have died, and the child is there.
Yeah, but if in this scenario, if you're in emergency situation for children, and you're worried that the condition is deteriorating or the child might die, you start your treatment without any delay.
We covered this topic really very well, Mohammed. And we appreciate very much you came forward to discuss this one, because we haven't covered it. And as you said, we don't cover it in teaching, or find very little about it in books. It's one of the weak points in our preparation for the FRCS. So thank you very much for covering this.
Yes, thank you for us for moderating, and thank you everyone for your experience, input, and important topic. And as I said, this is a topic that usually there is no right answer for. So if you have a format in your mind, you can easily do it.
Thank you, Mohammed. That's brilliant. Also, anyone who wants CPD certificate who attended, I have a list of people who registered. You could send me a message and let me know if you want a certificate. So that's the end of the teaching. I hope you all learned like me, and I found it interesting. We will end the session now. There will be a Viva session now after. Abdullah is going to lead the Viva. He's using a new approach to help with the clinical component. He's got a very good idea, and I think we need to move forward in our teaching and implement and adopt new ideas all the time.